Welcome you all to our inaugural Brain Injury Awareness Month speaker series led by the Acquired Brain Injury and Society team here at the Toronto Rehabilitation Institute. And we are so fortunate to have such enthusiastic members that are presenting today, in particular our trainees that do such outstanding work. And today, our first lecture is being presented by Vincy Chan, who many of us know. She is an award-winning PhD student in the Rehabilitation Sciences Institute here at the University of Toronto, and also works here at the Toronto Rehabilitation Institute, leading some major research initiatives. She has received numerous graduate awards and fellowships, including the Toronto Rehabilitation Institute Graduate Student Excellence Award, the Ontario Neurotrauma Foundation, Jane Gillette Pediatric Acquired Brain Injury Studentship, the Judith Friedland Fund for Oncology and Palliative Care. She has received a Brain Canada Award, as well as a very competitive CIHR Doctoral Award. And she's over 14 peer-reviewed publications and has co-authored 40 reports. And this work today is on older adults with acquired brain injury. Who are they and what can we do, is based on her master's thesis, which is published. So without further ado, I'm pleased to introduce Vincy Chan.
Thank you everyone for joining. And do we have anyone on the webinar, Julia?
Not yet.
Okay, well, for those of you who are here, if you have any questions, feel free to raise your hand, stop me anytime. So today, I'm going to be talking about older adults with acquired brain injury. Who are they, and what can we do? Acquired brain injury is an insult to the brain that affects the structure or function, resulting in impairment of cognition, communication, physical function, or psychosocial behavior. It's categorized into traumatic and non-traumatic brain injury, but today I'm going to be focusing on older adults with traumatic brain injury. So before I begin, I have a question for you. What do these leaders have in common? Jenny?
They have brain injury.
Yes, they both had a brain injury at some point in their lives. And it's very important to remember that brain injuries in older adults can also be lethal. So here's a statement from the Clarence House about the Duchess of Cornwall's brother, who hit his head while falling on a pavement and actually died because of a brain injury. So it really is more common than we think. Data has shown that a traumatic brain injury is more common than multiple sclerosis, HIV/AIDS, spinal cord injury, and breast cancer combined. And research has shown that over 30% will have a traumatic brain injury by the time they're 25, and it is also very common in vulnerable populations, including the homeless population and prisoner population. But what about older adults? So today I'm going to be presenting data from the Acquired Brain Injury Dataset, which is the first population-based dataset that captures the continuum of care for both traumatic and non-traumatic brain injury. And this dataset is led by Dr. Angela Colantonio, which started back in 2007. The ABI dataset uses healthcare administrative data sources from the province of Ontario. And today I'm primarily presenting from two data sources, the Discharge Abstract Database, which provides demographic clinical information on all hospital admission and discharges, including transfer and death. And our rehab data is going to be from the National Rehabilitation Reporting System, which provides us with clinical outcome and characteristics of rehab activity. And due to the publicly funded nature of our healthcare system, our ABI dataset is able to capture every single patient with a traumatic brain injury diagnostic code in Ontario, Canada. And we've actually published quite a bit with the acquired brain injury dataset, and as Dr. Colantonio mentioned, my master's thesis is published here in VMC Geriatrics and also a paper on outcomes after inpatient rehab. But our team has also looked at additional outcomes across the entire age population, such as factors that are associated with discharge from acute care, as well as factors that are associated with living setting after inpatient rehab. We also looked at alternate level of care days, which I'm going to go into a bit later. And alternate level of care days are delayed discharge from acute care. So we're going to start by looking at the hospitalization rate for a traumatic brain injury. Our data has shown that the highest hospitalization rates are actually among older adults. And here I have a graph that looks at the rates of hospitalization between 2003 and 2009. The dark blue line on the bottom represents older adults 65 to 74, the light blue 75 to 84, and the red line there are individuals 85 years and older. As you can see, we're seeing a steady increase in the rate of traumatic brain injury hospitalization, but across every single year, the rates also increase with age. So we're also curious in looking at inpatient rehab admission, and so we decided to compare some of our older data with some of our in-progress work right now. And the blue bar there is our work back in 2003, 2005, and the red bar represents some of our ongoing work on data between 2008 and 2011. And you can see there's a clear shift towards an older inpatient rehab population. If you look at the red bar under the green arrow there, we're seeing that the proportion of individuals between these age groups are lower, and that's because we're seeing a shift towards those that are 55 years and older. So then the big question is, if we're seeing this shift just 3 to 5 years later, what is it going to be like an additional 3 to 5 years? And are we ready for this increasing aging population in inpatient rehab? So we were also interested in looking at the sex distribution of older adults. A traumatic brain injury has typically been associated with younger men or younger male athletes, but we want to know if this trend holds true for the older adult population. And what we actually found is that the proportion of older females in acute care with a traumatic brain injury increased with age. The first part there, we're looking at those between 65 to 74 years of age. And in this age group, 36% were female. But when we're looking at those that are 85 years and older, 57% were female. So we're starting to see the shift in the traumatic brain injury profile from younger men to older women. So what is the most common cause of injury? Does anyone want to guess what the most common cause of a traumatic brain injury is?
In older people?
Yes.
Falls.
Yes, falls. It is the most common cause of a traumatic brain injury. And it also increased with age group. About 70% of those 65 to 74 were admitted in acute care with a traumatic brain injury because of a fall. But when we're looking at those 85 years and older, almost 90% sustain a brain injury from a fall. So given this increase in brain injury from fall, we want to know what is the most common cause of a fall? How are they falling? Is it on stairs and steps, on the same level? And so we've actually found that the most common types are on the same level and on stairs and steps. And here we're looking at a graph that looks at this distribution of age group by different type of specified fall. And I think the highlight of this graph here is that even though falls on wheelchair and walker are only about 2% of the population, 56% of these falls are among older adults 85 years and older, sorry. And so we've already just established that we're seeing an aging population. So the big question is, should our prevention strategy also start looking at different type of falls, including wheelchair and walker? And are we going to start seeing an increase in this type of fall later on in 3 to 5 years? So what kind of services are used in acute care? How long do they stay? Are they an intensive care unit? And so we started by looking at the length of stay in acute care by age group between 2007 and 2009. And we found that the days in acute care actually increased with age. About 33% of those 65 to 74 years of age were in acute care for 12 days or longer. But during the same time period, among those 85 years and older, 41% were in there for 12 days or longer. But on the other hand, the use of intensive care units decreased with age group from about 34% to 17%. An alternate level of care days are actually days that are delayed discharge from acute care. So it means the patient is ready to be discharged, but they are still occupying an acute care bed because they're waiting for a more appropriate discharge destination. And it is very costly not only for the healthcare system, but also for the patient. And so we wanted to look at the proportion of older adults with an alternate level of care day. And when we looked at the entire Ontario population, aged 19 years and over with a traumatic brain injury, we found that 72% of these ALC days were among older adults. And when we controlled for factors such as sex, comorbidity, rural geography, we found that older adults were significantly more likely to have ALC days compared to those 19 to 54 years of age. And so we wanted to know, where do they go after acute care? Do they end up going home? Do they go to long-term care, inpatient rehab? And we found that the proportion that are discharged from decreased from 59% to 36%, but the proportion that also go to rehab also decreased from 13 to 8%. The proportion that die in acute care increased from 14 to 29%, as well as those that go to complex continuing care, long-term care, or transfer to another inpatient facility. So there's a lot of talk right now about aging at home and improving functional outcome, and one way for this is to provide services for inpatient rehab. So we wanted to see, do older adults actually benefit from inpatient rehab? And one way we looked at this is to look at the functional outcome. So in the NRS, functional outcome is measured by the Functional Independence Measure score, which assesses the physical and cognitive disability of an individual. There are 18 items for this score, and each is scored from 1 to 7. So if you have a total score of 18, it would indicate total dependence, while a score of 126 would indicate total independence. So this graph looks at the average FIM score at admission and at discharge between 2003 and 2009 by referral destination, as in where they ended up going after inpatient rehab. And we can see that across all referral destinations, older adults make significant gains, as in their discharge score was significantly higher than their admission score by at least 20 points overall. And what is really important is that we found out that even though older adults are admitted with significantly lower score than the younger adult, and they leave rehab with significantly lower score, the change that they make is actually the same. It's not statistically different, meaning that like younger adults, older adults make similar gains in inpatient rehab. And finally, we want to look at the comorbidities of older adults with a traumatic brain injury. There are many, many ways to look at comorbidity using healthcare administrative data. And one way we looked at this in the acute care is to look at the Charlson Comorbidity Index. The Charlson estimates the risk of death from comorbid disease, and we found that for those with traumatic brain injury, the most common type of Charlson comorbidities were those with diabetes with no organ failure, dementia, and diabetes with organ failure. But we also wanted to know what kind of comorbidities they have while they're in inpatient rehab. And here we're looking at the full range of comorbid health categories that are provided in the National Rehabilitation Reporting System. We're looking at the comorbidities by sex. The red bar indicates female and the dark blue male. And we can see that the most common types of comorbidity in inpatient rehab are circulatory system, endocrine, nutritional, metabolic, immune system, and nervous system. But when you're looking at females, the musculoskeletal system is very common too. So the takeaway message from this very busy graph here is that comorbidities are very prevalent among the older adult population. And across almost all types of comorbidity, more females are having comorbidities of these conditions. So given that comorbidities are so common in rehab, we wanted to know if comorbidities influence rehab outcome. And this is an ongoing work that we're doing right now, looking at comorbidities using the Johns Hopkins Aggregated Diagnosis Group, which takes into account comorbidities in the 2 years prior to admission. And we found that while controlling for demographic, clinical, and environmental characteristics, each increase in the number of ADG decreased the length of stay in rehab by 37%. But at the same time, it also significantly decreased the motor and FIM score by 18 and 7% respectively. So I just bombarded you with a lot of data, so I'm going to try and summarize it with talking about what can we do now. And perhaps the most obvious is falls prevention. We already established that falls are the most common cause of traumatic brain injury and that the type of falls differ by age group. And so needless to say, screening for a brain injury after a fall is very, very important. A recent study by Gardner and colleagues found that those with mild traumatic brain injury at 65 years or older had an increased risk of developing dementia. And so it's very important to screen for a brain injury, even if we're catching only mild brain injury, because it can have very lasting and long-term outcome. We also need to look at prevention strategies that address different type of fall. And this increase in older adults with traumatic brain injury and the increase predominantly by fall is not just seen in Ontario, it's actually seen worldwide. Harvey and Close in Australia also found that the rates increase and is predominantly driven by fall in the oldest old. And what they did is they actually took a step further and looked at the type of traumatic brain injury, and they found that the greatest increase was actually in intracranial hemorrhage, suggesting that in addition to looking at the causes of fall, we need to look at why they're falling. Is it due to some external factor or some medication that they're taking? Older adults should also be referred to inpatient rehab. We showed that older adults make significant gains, so older age should really not be a barrier to accessing inpatient rehab service. And we also need to take into account the demographic transition towards older adults, and in particular older female in inpatient rehab. Alternate level of care days. We also need to prepare for and address the anticipated increase in ALC days by the older population in the near future. We also need to start addressing comorbidities. Comorbidities influence rehab outcome, and the types differ by sex. So a multidisciplinary approach is needed to address comorbidities in the inpatient rehab setting. We also should be aware of the full range of comorbidities so we can help treat and incorporate them into the rehab program and to prevent missed or delayed diagnosis. And finally, we need more research on guidelines and treatment. There's currently very specific guidelines for children and also concussion guidelines based primarily from sports. But research on guidelines and treatment specific for older adults is needed so we can ensure appropriate and effective care is provided. Thank you so much for joining me this lunchtime. And before I finish, I need to disclose that this study was supported by the Ontario Neurotrauma Foundation, National Institute of Health, and through provision of data by ISIS and Cancer Care Ontario. And doctoral support for my research is from CIHR, Ontario Neurotrauma Foundation, Brain Canada, Pediatric Oncology Group of Ontario, and CIBC. Before I finish, I'd really like to invite anyone to join us for an IDAP tour from 1 to 2 p.m. if you haven't seen it already. And we're actually going to be meeting here in this room at 1. And do join us for the rest of our speaker series. Tomorrow, Dr. Tatiana Moliva is talking on disorders of sleep and wakefulness in persons with traumatic brain injury at 500 University. Thank you.